Hello, dear colleagues. Today will be the second part of my HLH lecture devoted to our center experience in managing of patients with secondary HLH. Today we'll talk about the group of patients and the particular case reports of patients with secondary HLH. Our group is 91 patients. Not all of them were in our department because we treat only adult patients, but our doctors were called for medical conference to other hospitals. So average age is 58 years old. The main triggers were blood malignancy, 52 patients, including ones with lymphomas, 33 patients. Only 5 patients had EBV infection, and I think it's no good because in real practice the amount of such patients is much more. 10 patients had another infection problems such as leishmaniasis, pneumococcal severe pneumonia, and HIV. 5 patients had connective tissue diseases, but I think that in the real practice of our city, the number of such patients is much more. But they usually have very good response to steroids, so I think a lot of them were underdiagnosed. But even if the secondary HLH will be put in them, the strategy will be the same. Some patients in our group had allogenic stem cell transplant, and only 10 of patients had cryptogenic secondary HLH. In the other groups, the amount of cryptogenic is more, but I think that it depends on the diagnostics possibility of the particular centers. What manifestations had our patients? The man with the HLH looks like septic one, so almost all of our patients had high fever. But it's worth to say that some of them with very high ferritin, with cytolytic syndrome, with cytopenia, or other features of HLH had a normal body temperature. That's why lack of fever does not exclude the secondary HLH. Cardiovascular symptoms had less than 10%, and rash had 15%. The most frequent complaints were CNS symptoms, including seizures and severe fatigue, and more than half patients had shortness of breath, non-cardiogenic pulmonary edema. What about laboratory signs? All patients had laboratory evidence of liver impairment, and almost all ones had very high ferritin, more than a few thousands or tens of thousands of ferritin. The evidence of the hemophagocytosis in the bone marrow was quite high, more than 80%. But I think that's why, because we had very experienced pathologists, Dr. Patikhonova Nadezhda Alexandrovna, who worked in this field for 20 years. And in really practices of other centers, I think that the morphological evidence of the hemophagocytosis is not so high. 80% has high triglycerides. It's hard to say the reason of high triglycerides in these patients. possibly because this is the dysfunction of the lipoprotein oxidase, but maybe this is only a theory. And more than 60% of such patients had low blood coagulation, especially low fibrinogen. It's thought to be a subtle DIC, and and some of these patients had numerous transfusion of the fresh frozen plasma, and without treatment of secondary HLH, these transfusions had totally no effect. What about treatment? We in general used immunoglobulin, etoposide, glucocorticosteroids, and some other drugs. And in our daily practice, it was very hard, especially at the beginning of our HLH work, to venture and to give etoposide to the patients with a very bad condition. Low counts with, for example, 0 of the leukocytes, with 0 of the fibrinogen, with 2 platelets, with low blood pressure, and so on. We were afraid that etoposide will worsen their condition and will kill them. But it looked, as I have already said, a bucket of water in the wood fire. Their condition very fastly improved after etoposide. So on the slide we see that treatment of the patient with secondary HLH leads to much better survival than no treatment of patients with a very bad condition. What about case reports? We talked about the group of patients in general. How does it work? We had a patient with acute myeloblastic leukemia, 53 years old. She had got allogeneic hematopoietic stem cell transplantation, which leads to marked improved of survival of patients with acute myeloblastic leukemia. But after 3 months, she was admitted to us with signs of liver impairment and with the increase in pancytopenia, low platelets, leukopenia, and anemia. We thought that this is, of course, graft versus host disease, but the usual treatment wasn't effective in her. And after a few days, she had febrile fever resistant to any antibacterial, antimycotic, and antiviral drugs, and resistant to intravenous immunoglobulin. The examination of her showed no evidence of infection, but CT picture showed of her lungs showed a subtotal alveolitis. After a few days, she had very severe shortness of breath, and had to begin mechanical lung ventilation. And after 25 days of the onset, after the onset of the disease, she died due to multiple organ failure. Now we know that it was secondary HLH with severe multi-organ failure. The other patient was 30 years old. She lives in St. Petersburg, but 2 months before, she returned from Hispania, where she had a rest. After 2 months, she was admitted to us with fever, moderate pancytopenia, evidence of liver impairment, very mild, high ferritin, only 700, spleen, enlargement 21 centimeter, and positive PCR tests for EBV. We thought that maybe this is the acute EBV infection, especially because during our examination she spontaneously improved. So she was discharged. After 2 months, again, she had a high fever, recurrence of pancytopenia, liver impairment, and enlargement of her spleen and high ferritin. We examined her, but we didn't find any evidence of localized infection, including EBV, leishmaniasis, or something else. No evidence of malignancy, as well as no effect from anti-infective therapy and steroids. We thought that it is the hemophagocytic lymphohistiocytosis, secondary HLH, maybe cryptogenic. So we initiated course HLH 2004. Now we don't use the pediatric schemes and use the etoposide only. So we started the etoposide and cyclosporin, the dexamethasone treatment. And the effect was quite perfect. Fast resolution of cytopenia, normalization of the fibrinogen, normalization of the body temperature, reduction of splenomegaly, and reduction of ferritin from 6,000 to only 1,000 nanograms per milliliter. But in spite of chemotherapy, after 3 weeks, again deterioration, rapid growth of the spleen, and relapse of fever. We performed splenectomy, and we diagnosed secondary HLH because of leishmaniasis. The Mediterranean variant of leishmaniasis is very hard to detect because in Russia, in that time, we had only morphology, no serologic tests and no PCR. And 3 quite experienced doctors reviewed her slides, the liver slide and the bone marrow and the blood, and they said that there are no leishmania. We gave her amphotericin B before and had no real effect. So we repeated the therapy with amphotericin B, and the outcome was perfect. In that situation, of course, it's no good to treat leishmaniasis with etoposide. Amphotericin B is the best drug in that situation, or maybe surma. But etoposide gave us time to think and to put the correct diagnosis. 7 years passed, she feels well. Another patient, 37 years old, he had HIV infection, hepatitis C, and he had high active antiretroviral therapy. After 7 years, he admitted to us with a diffuse large B-cell lymphoma with spleen, cervical, intra-abdominal lymph nodes impairment. And he had severe, strange autoimmune hemolytic anemia. During the 2 weeks, he received glucocorticosteroids, rituximab, chemotherapy, CHOP-like regimen with etoposide and multiple blood transfusion. But in spite of that, his condition worsened from hour to hour. And the last days, we saw jump-like elevation of the LDH, bilirubin, liver function tests, and his ferritin was 90,000 nanograms per milliliter. His anemia was very severe, 1.8 gram per deciliter. When we saw his ferritin, we understood that this is secondary HLH, but what can we do? Because we gave him all that we had, steroids and etoposide. So we decided to give him intravenous immunoglobulin, and the result was also perfect. The next day, we saw a rapid fall of ferritin, and as well as liver function tests and bilirubin. Fibrinogen for 2 days was quite low, but in a week this value also improved. And his hemoglobin level fastly improved after blood transfusions. And we continued to treat him from his lymphoma. He completed the chemotherapy. His blood values came to normal, and he returned to daily life for years. What was the cause of secondary HLH? We don't know, because in spite of the effect of chemo, it persisted. But in that situation, immunoglobulin calmed the immunity and I think cured our patient. One more. He was 19 years old and his main diagnosis with systemic lupus erythematosus. But suddenly, rheumatologists saw a strange picture. He developed leukopenia and had got high fever. Soon he had hepatosplenomegaly, which was palpable. The sizes were big. Episodes of loss of consciousness, very debilitating fatigue, and vasculitic-like rash on extremities. And his liver function tests showed cytolysis. That was the rash. We diagnosed EBV because of detecting the IgM to capsid antigen of EBV. It is quite specific diagnostic tool in EBV diagnosing. And when he came to us, we saw the high ferritin level, 31,000, and increase in pancytopenia and low fibrinogen. After one infusion of etoposide, he markedly improved. The fever resolved and everything was well, but ferritin was quite high. In a week, it was 11,000. We thought that this will be come to normal a little bit later. But after a week, suddenly he had a relapse of fever, disorientation, grimacing, and sopor. In his blood pressure was low, arterial hypertension. So we decided that maybe it's worth to give more etoposide. In a few hours, everything came to normal. And after that, every week on Thursday, he had 150 milligrams of etoposide 6 times. But after 6 weeks, the temperature came to normal. He spontaneously improved. We thought that it was the severe EBV infection which could kill him, but we calmed the immunity by our etoposide, let him over-survive the EBV. 3 years passed, he feels well. And one more patient. She was 25 years old when suddenly joint pain appeared. After 2 months, rash and fever added, and she admitted to the hospital. During the next month, she received antibiotics, steroids, including pulse doses, cyclophosphamide, plasmapheresis, but in spite of that therapy, her condition worsened. She had fever and very severe pain in the skin. She was like being in fire. When hematologists were called, her liver function tests were also elevated. We see that AST is more than ALT and very high ferritin, 55,000. We decided that she has cryptogenic hemophagocytic syndrome. So we gave her etoposide and cyclosporin. It was a few years ago, and now we don't use cyclosporin to treat HLH. And the result was also perfect. The next day after etoposide, she stopped. Her body temperature normalized and her pain resolved. In a week, her skin markedly improved. But after 1 week, her fever returned, but she tolerated it much better. Her fever continued for 4 weeks, and after the month, after the initiation of the etoposide treatment, her condition improved, liver function test normalized, ferritin dropped to 2000, and she was discharged. Now, 7 years passed, she feels well. So, laboratory and clinical manifestation of secondary HLH fit the published data. The main causes in our group was blood malignancy, but in other works, EBV-HLH is also very common. It's crucial to exclude lymphoma, EBV infection, collagenoses, and leishmaniasis in all patients with the secondary HLH, and effective treatment leads to fast clinical improvement. Laboratory improvement will usually normalize later. That's all that I wanted to say. I will be very grateful for any feedback or questions. Thank you for your attention.